the commonest inflammatory mediator, which stimulates this PML, that is polymorphonucleonucleosides, to release the further inflammatory mediators. And this inflammatory mediators then causes the severe inflammatory response syndrome that we call as sepsis, manifested by symptoms such as hypotension or increased respiratory rate or hypoperfusion and others. Now, the main part of my presentation is diagnosis. How to move towards the diagnosis of sepsis. Now, when a patient comes with suspected infection, when to suspect sepsis? When a patient comes with suspected infection, who are likely to have a prolonged ICU stay or die in a hospital, can be promptly identified at the bedside with Q-SOFA score, that is quick sequential organ failure assessment score. What is this Q-SOFA score? It consists of three basic elements. One is alteration in the mental status. Second is systolic BP, blood pressure of less than 100 mmHg, or a respiratory rate of more than 22 per minute. Using these three basic elements, a Q-SOFA score is graded either 0, 1, 2, or 3. Each of the element is given a score of 1, and a score of 2 is likely that the patient has a sepsis and has a prolonged ICU stay or could have a higher mortality. So based on Q-SOFA score, this can be we can have suspect this patient with an infection with a sepsis and judge about his mortality rate or his prolonged hospital stay. This can be used to identify patients also at risk of sepsis in out of hospital settings or emergency department and general hospital ward settings. We have a very detailed sequential organ failure assessment score also. If you can see from the chart, this sequential organ failure assessment score uses the signs and symptoms from the basic 6 systems. One is the respiratory system, wherein we use the ratio of partial pressure of oxygen to fractional inspiratory pressure of oxygen, or the coagulation system, wherein we see the platelets counts, or we see in the bilirubin level from the hepatobiliary system, or in the cardiovascular system we see the mean arterial pressure, or in the CNS system we see the Glasgow Coma scale, or in the renal system we see the creatinine level in milligram per deciliter. So each of this system has a value which with the abnormal values is given a score from 0, 1, 2, 3 to 4. And a SOFA score of more than 2 carries a higher chances of sepsis, mortality, or prolonged hospital stay. For example, if a SOFA score of more than 7 to 9 has a mortality of about 10 to 15 to 20%, but a SOFA score of more than 10 carries a mortality of about 40%. So higher the SOFA score, the higher the chances of mortality due to sepsis or prolonged hospital stay. So this chart can be used for suspecting patients with infection with severe sepsis. Now let's consider a few points about in diagnosing sepsis. Appropriate routine microbial culture should be obtained before initiation of antimicrobial therapy from all potential sites of infection. If an antimicrobial therapy has already been given, if an empirical therapy has already been initiated, then before the next dose of the antibiotic or the antimicrobial, the blood cultures or any such potential site of infection culture can be taken. This may include blood, respiratory secretions, urine, cerebrospinal fluid, wounds, and other body fluids. If it is not logically possible to obtain culture promptly, say about 45 minutes, if you're not able to collect the sample promptly, the appropriate empirical antimicrobial therapy should be administered. The empirical therapy should be based on the hospital or the healthcare setting antibiogram or the local antibiogram, or as per the hospital antibiotic policy. In sepsis or septic shock patients, the diagnosis includes identification of a specific anatomic site of infection. Requires emergence source control. This is very important. Source control is the most important measure if you want to control this ongoing sepsis. Now see the R1 is also called as the golden hour of sepsis. What is the golden hour of sepsis? It includes a time 0. This is the 1 hour from the time 0 or the time of presentation. What is time 0? Time of presentation. It is a time of triage in the emergency department, or if presenting from another healthcare facility, from the earliest time point in the treatment chart wherein the patient had all the features consistent with sepsis. From the time 0 till the 1 hour is the golden hour, wherein we implement the care bundle for sepsis. Now, what does this care bundle include? It consists of 5 points. These 5 points could be followed in the first 1 hour of presentation, and these 5 points include one first point is measure the lactate level. Remeasure if the initial lactate level is more than 2 millimoles per liter. The measuring lactate level is the first point, first part of the care bundle. The second parameter of the care bundle includes obtaining the blood cultures before administering antibiotics. As said before administering antibiotics, or if antibiotics have already been administered, then before the next dose of the antibiotic. The third, administering broad spectrum antibiotics. Based on the hospital antibiotic policy, administration of the broad spectrum antibiotics. Then fourth, begin rapid IV administration of 30 milliliter per kg of crystalloid for hypotension or lactate level of more than 4 millimoles per liter. Then fifth and the last is the applying vasopressor if the patient is hypotensive during or after food resuscitation to maintain the mean arterial pressure of more than 65 mmHg. So these are the 5 parameters that should be followed when a patient comes to with suspected infection suggestive of sepsis and during the first 1 hour, which we call as the golden hour, and this is the care bundle for this sepsis. Let us have, before proceeding to the details of this the parameters for diagnosis of sepsis, let us have a quick view of the diagnostic criteria for suggestive sepsis. One is fever, wherein the fever threshold is about more than 38.3. Another is tachycardia, rate of more than 120 per minute, or systolic BP less than 90 mmHg, or procalcitonin level of more than 0.5 nanogram per ml, or bandemia, that is the presence of toxic bands of more than 5%, or lymphocytopenia of less than 0.5 into 10 to 3 per microliter, or neutrophil to lymphocyte ratio of more than 10, or thrombocytopenia less than 150 into 10 to 3 microliter, or a lactate level of more than 2 milliequivalent per liter. So these are the diagnostic features suggestive of sepsis. Let us move towards the details of the diagnostic features. However, the challenges in diagnosis of sepsis, let us before proceeding into details, let us see the challenges. The challenges are that initial signs and symptoms of sepsis are frequently non-specific, which leads to a delay in diagnosis. Elevated WBC count, neutrophilia, or eosinopenia are frequently used to diagnose bacterial sepsis. However, these variables have a very low diagnostic value. Also, there is an issue with blood cultures. Blood cultures are only positive in 20 to 30% of the patients with sepsis, though gold standard, but the chances of positivity is very less. Moreover, it takes about 2 to 3 days before the results becomes available. So we have to depend on the early onset markers of sepsis along with the blood cultures. Now, the clinical diagnosis of sepsis can be challenging, and microbial tests are unhelpful. They're taking days to come. Several biomarkers have been developed to assist in the early diagnosis of sepsis, which includes CRP, that is C-reactive protein or procalcitonin, and many more recently, including the circulating cell-free DNA. And recently, I have seen one of the article which was mentioning about magnetic resonance, TRMR, magnetic resonance, which details of the magnetic resonance of the inflammatory mediators, which can help in the diagnosis of sepsis. As I said before, the most important and the gold standard for diagnosis of sepsis and most specific is the blood culture. It is a only diagnostic testing that currently has a confirmed role in sepsis diagnosis, in pathogen identification and sensitivity. Obtaining blood cultures is recommended by all the previously described guidelines. It is important that this can be done before the administration of antibiotics, and because the antimicrobials or the antibiotics can quickly sterilize the blood cultures once administered. Hence, before antibiotic administration, blood cultures should be collected. Blood cultures is considered to be the gold standard for diagnosis blood-borne infections. Now, what are the key steps? One is for blood culture. One is the best available site for culture should be selected. Another is the aseptic technique should be followed for blood culture. Then third is adequate volume of the blood should be taken for the blood culture diagnosis for sepsis. Then fourth is the sufficient number of blood culture sets should be collected for blood culture. And lastly, is the timing of the blood culture. Let us see in each of the details of this key step for blood culture. Blood culture is very important for the diagnosis of sepsis. Let us see each of the parameters of blood culture for a quick diagnosis of sepsis. Best available site. Now, best available site is the anticubital veins are preferred. There is no difference between the arterial blood or the venous blood. However, blood should be avoided from drawing from the lines. Sites should be selected such that it has a low contamination rate, and it is easily accessible, readily available, and it causes minimal discomfort to the patient. In short, blood culture should be done from such a site that it carries a low chances of contamination. Now, aseptic technique, this is another most important thing. Asepsis should be followed. Most sterile precautions should be followed. It's a part of the care bundle for blood culture collection. That contamination should be avoided during blood culture. It can be done by cleansing the site with 70% isopropyl or ethyl alcohol and allowed to air dry. And the second cleansing should be performed using 1 to 2% tincture of iodine or 10% poured in iodine solution, or 2% weight by volume chlorhexidine can be used for the second cleansing. Now, contamination of blood culture should be avoided. If the initial contaminants are there during the collection for blood for culture, it can be from the skin flora or in the pre-analytical phase. And late contamination after 2 to 3 days of the blood culture inoculation might be because of during the transit or the transport time. So contamination should be avoided in collection of blood cultures. Now, blood volume. There's a direct relation between the volume of the blood and the detection of the bacteremia. Blood volume of each culture set. Now, what do we understand by culture set? It's very important to note. A culture set means, understanding set means all the number of bottles that we take it from one single prick contributes to one set. If you take 2 bottles from one prick of the body, that 2 bottles consist of one set. If you take 3 bottles from that one prick, it's the 3 bottles of one set. If you do 2 pricks on both the hands, that means, and collect the bottles from the 2 pricks, that means we are collecting 2 sets. So every prick corresponds to one set with respect to the number of the bottles that we collect from each prick. So blood volume of each culture is the single most important variable in recovering microorganisms. When the volume of blood increases from, say, about from 2 to 20 ml, the yield also increases from about 30 to 50%. A study was showed from Coercive et al. Showed that for adults, the optimum volume is about 20 ml per culture. And the most important thing, sets. As I said before, sets correspond to the prick. 2 or 3 blood cultures are adequate for detecting episodes. Ideally, one set from a left hand and another set from the right hand is ideally should be done. If the patient is on a center line, then and it has a now and from paired bottle should be collected from each of the lumens. If the patient is on center line, paired bottles should be collected from the left hand, from the right hand, along with the lumens. Now, paired bottles means one of the bottle is aerobic and another bottle is anaerobic. And the most important thing, always it has been seen that clinicians often ask for both the paired bottles should be of aerobic. Understanding this thing, it is a very important thing to consider that not all the organisms are strictly aerobic or anaerobic. With the common organisms like E. coli, Klebsiella or Staphylococcus streptococci are facultative to anaerobes. E. coli, Klebsiella being, as we have seen, the commonest organisms in our healthcare setting in India amongst the gram-negative pathogens. E. coli, Klebsiella are facultative to anaerobes. They can grow in presence of oxygen as well as in absence of oxygen. So this facultative anaerobes, it has been observed that they grow faster in anaerobic bottles. If you load both the aerobic and the anaerobic bottles simultaneously in the bactec or the bacterial instrument, it is the anaerobic bottles which flash about 2 to 4 hours early than the aerobic bottles, because these organisms are facultative anaerobes. So they flag first. So hence it is advised to the clinicians to collect anaerobic bottle along with an aerobic bottle, because some organisms are strictly aerobic, some organisms are facultative anaerobes, and some are anaerobic. So the set should consist of one aerobic and one anaerobic bottle, and 2 sets should ideally be collected, one from the left hand and from the other from the right hand. And if the patient is on center line, set should be collected from the center line also. So using conventional non-automated blood culture found that total of 20 ml per set gives a proper result. If we take about 8 to 10 ml from the per bottle, from one set we get about 20 ml. And if we collect 2 sets, then it comes about 40 ml. That further increases the chances of isolation of microorganisms. So the blood culture set is useful to interpreting the clinical significance of positive blood culture. One positive test is sufficient for primary pathogens like E. coli and Klebsiella. The E. coli, Klebsiella proteus, Pseudomonas, Acinetobacter are primary pathogens. For them, one positive set is okay, but for the opportunistic pathogens like cons, that is Coagulus negative Staphylococcus species, then we need two sets is a must. So say I got only why two sets are important. People clinicians often ask why two sets. If I get a commensal or a contaminant from one set only, this second set can be used to label it as a contaminant. If the second set doesn't hit any organism, then the first set organism of cons or commensal or contaminant is labeled as a contaminant. But if the commensal or the contaminants are isolated from both the sets, that means it is an opportunistic pathogens. Hence, the microbiologist always advises for a set of bottles from both the hands to rule out any contamination or commensal and or opportunistic pathogen. Opportunistic pathogens are regional flora need more than one culture set for interpretation, as I said before. It is not appropriate to create only a single blood specimen for culture. A single blood culture will not have a sufficient volume for the optimal detection of bacteremia and fungi. Now, what is the timing? No, this is another important thing. It is seen that chills and rigors occurs 1 hour after the one set of the infection. That is the lag period. And also another thing, fever follows chills and rigors. Therefore, some studies, some recommend collection of the blood culture soon before the chills or rigors of the fever spike. The optimal time for the collection is just before the one set of shaking chills or rigors. However, this is not possible. It is not possible to anticipate the precise timing of chills or rigors. It is a common practice to draw the blood cultures when fever is detected. Hence, there is a lesser chances of detecting positivity blood cultures. It is reasonable to obtain two blood culture sets simultaneously, especially if antibiotic therapy is going to be initiated. In less urgent situation, blood cultures may be spaced at intervals. Blood culture may be spaced at intervals to detect, so that there we can detect the transient bacteremia also. Because bacteremia is not present at all, it is not most of the time continuous, it can be transient also. So blood cultures can be maybe spaced at intervals. So that was about blood cultures, which is a gold standard for diagnosis of sepsis. Now let us see about the molecular strategies. The molecular strategies to improve pathogen detection includes a number of molecular approaches have been, such as conventional, such as PCR, have been suggested, such as MALDI-TOF, which stands for matrix assisted laser disruption ionization time of flight mass spectrophometry. This has now become common in most of the bigger hospitals in the metropolitan cities. That MALDI-TOF is being used for identification of organisms from positive blood culture bottles. A positive blood culture bottles takes about 8 to 12 hours for the colonies to grow, and from the grown colonies, a MALDI-TOF can identify the pathogen within few minutes. So MALDI-TOF can reduce the time to detection from organism as compared to conventional culture-based identification to about 4 hours. So MALDI-TOF is one of the molecular strategy for the earliest identification of the pathogen of a suspected sepsis patient blood sample. Another strategy is the extraction and amplification of microbial nucleic acid from a positive blood culture and subsequent hybridization on a microarray platform like BioFire to detect the which also detects the antimicrobial resistance genes such as MECA genes or Guillain-Barré genes and CPU panel genes of bacterial species. However, the shortcomings of this molecular strategies is that there is an incomplete coverage of the pathogens. Only a defined set of pathogens get identified from these molecular setups, and also the inability of this test to be applied directly to the biological sample. We have to wait for the growth or for the culture to flag or the growth to come. It cannot be directly tested directly from biological sample. And the major limitation of this molecular is there is an inavailability of the antimicrobial susceptibility. However, this can be also dealt with. We have UCAST guidelines, that is European Committee AST guidelines, which gives guidelines on interpretation of the antimicrobial sensitivity done from direct blood sample. A direct blood sample can be plated on a Muller-Hinton agar with antibiotic disc plate on it or yeast strips on it, and we can interpret it using the UCAST guidelines instead of waiting as a conventional way for the blood colonies to come and then to apply the disc on it, which will take about 24 to 48 hours. So direct antimicrobial sensitivity from the blood sample can be done using the UCAS guidelines. So that was about the molecular strategies. Now moving to the biomarkers, as I said before, blood culture takes time. It's also less sensitive. The other alternative to us for the diagnosis of sepsis is the biomarkers. The origin of the biomarkers is in relation to the pro-inflammatory cascade is activated during the sepsis. If coming back to again to the pathobiology and to understand the biomarkers of sepsis, the PAMs released from the pathogens and the DAMs released from the damaged tissue stimulate the host immune cells to release interleukin C or the tumor necrosis factor alpha or interleukin 1 beta, which in turn predominantly by the interleukin 6 stimulates the PML, that is poromorphonuclear leukocytes, that is monocyte, neutrophils, or the macrophages to release inflammatory mediators such as STRAM1 or trisepsin or super or CD64. Each of the inflammatory mediators will be dealing in details in the next successive slides. These inflammatory mediators are released from these PMLs, which also again in turn interleukin stimulate the liver to release a C-reactive protein, which also interleukin also may stimulate the parenchymal tissues, activate the parenchymal tissue to release procalcitonin. So which is another inflammatory mediator which can be used as a biomarker of sepsis. So this procalcitonin released from the parenchymal tissues or the C-reactive proteins released from the liver in response to activation by interleukin 6, it can be used as biomarkers of sepsis, or the STRAM1, trisepsin, CD64 or super released from the PMLs in response to activation by interleukin can be used as biomarkers of sepsis. Now let's see the details of each of these biomarkers. Before going into details, let's have a quick review of the diagnostic value and the limitation of these biomarkers. If we see the C-reactive protein, the sensitivity is about 0.75 and specificity is about 0.67. However, the limitation of the C-reactive protein is that it is independent of infection severity. It increases in many other inflammatory diseases also. If you see procalcitonin, it has a better sensitivity and specificity, that is 0.77 and 0.79. However, it also too increases in various non-infectious cases also, like cardiac arrest and severe trauma. If you see interleukin 6, it is highly sensitive, though less specific, but there is a limited data on its results. STRAM1 also has a sensitivity of about 0.7 and 0.8. However, the limitation is present in inflammatory disease without infection also. Lipopolysaccharide, it has a lesser sensitivity, but specificity is higher. It's a non-specific marker of inflammation. Similar to the super, which has a very limited data. We'll go into each of the details of these biomarkers. First, we see the most commonly the cost-effective method of diagnosis of sepsis is the C-reactive protein. C-reactive protein is an acute phase reactant protein which is released from the liver after stimulation predominantly by interleukin 6 and other cytokines. During infection, C-reactive protein has both pro-inflammatory and anti-inflammatory effects, as it mediates elimination of pathogens, but also inhibits the interaction between the leukocytes and endothelial cells. The secretion of the C-reactive protein is started 4 to 6 hours after stimulation, and it peaks at 36 hours. CRP is frequently used for the diagnosis of infection. A meta-analysis showed that its sensitivity of 0.75 and specificity of 0.67. In critically ill patients with sepsis, elevated CRP levels on ICU day 1 could differentiate between patients with and without sepsis. CRP level decreases over the first 48 hours when successful antimicrobial therapy is initiated. So that was about C-reactive protein. It's commonly used as a biomarker of sepsis. Another commonest marker is the procalcitonin, which is recently been used in increased cases. It is a prohormone of calcitonin, which is normally produced in the C cells of thyroid gland. In healthy humans, all procalcitonin is glued to calcitonin, and only less than 0.1 nanogram per ml is measured in the blood. Massive reduction of procalcitonin in the bloodstream occurs, which depends on the sepsis severity. Procalcitonin shows a favorable kinetic profile than CRP and cytokines, as its levels increases within 4 to 12 hours after the onset of infection. It has a sensitivity of about 0.77 and a specificity of 0.79. For critical ill patient, the cutoff of procalcitonin is about 1.1 nanogram per ml. Patients with sepsis shock have the highest procalcitonin levels, averaging between 4 to 45 nanogram per ml. Circulating procalcitonin levels decreases with the half time of about 24 hours when the infection is sufficiently treated. Dropping procalcitonin levels associated with improved survival rates, while increasing or persistent elevated procalcitonin levels are predictive for an unfavorable outcome. However, procalcitonin also increases in non-infective situations such as severe trauma. Another biomarker with less used is CD64. CD64, that's cluster of differentiation 64. It is an IgG binding receptor which is expressed by neutrophils, monocytes, and macrophages in response to cytokines released during bacterial infection. Because it is being bound to the cell, the current method of choice for detection or analysis of CD64 is the flow cytometry. And the available data indicates that it's a high sensitivity, about 86%, and a high specificity, 87%. However, the lab should be equipped with flow cytometry for the detection of CD64. Another biomarker is perception. Regarding perception, it is by activating a pro-inflammatory signal cascade on contact with infectious agents. CD14 has a role as a recognition molecule in the innate immune response against microorganisms. The soluble form of CD14 is called as perception. Perception is normally present in very low concentrations in the serum of healthy individuals. However, it increases in response to bacterial infection. It has been found with a cutoff of 600 picogram per ml, a sensitivity of 78%, and specificity of over 61% at a cutoff of 600 picogram per ml. So perception is another earliest biomarker of sepsis which can be used with very good sensitivity and specificity. Another is STREM1. STREM1 is the triggering receptor which is expressed on myeloid cells. A STREM the soluble form of TREM1 is a member of immunoglobulin superfamily, which is upregulated on phagocytes after exposure to bacteria and fungi. During sepsis, activated phagocytes release a soluble form of TREM1, which among other body fluids can be found in plasma. It has a sensitivity of 0.79 and a specificity of 0.8. It's a very good sensitivity specificity. However, it has also been found in other inflammatory diseases without infection. Another biomarker is a lipopolysaccharide binding protein. It is an acute phase reactant protein that forms a complex with lipopolysaccharide, which is an endotoxin released from the gram-negative organisms. Lipopolysaccharides and lipopolysaccharide binding protein binds to CD14 and to toll-like receptors on the immune cells, resulting in the transcription of cytokines and other pro-inflammatory mediators. So at a concentration of 5 to 10 microgram per ml, it is normally found in human serum. But in sepsis, LBP levels increase to about 30 to 40 within 24 hours. However, it is a non-specific marker and does not detect resolution of sepsis or is a predictor of outcome. Another biomarker is SUPAR, that is soluble form of urokinase type plasminogen activator, which is a new biological marker of immunological activation. Urokinase type plasminogen activator receptor participates in the migration of the inflammatory cells from the bloodstream to the tissues against infection. During inflammatory stimulation, UPAR is cleaved from the cell's surface by proteases to create a soluble form which can be detected into blood, urine, and CSF. Another biomarker is adrenomedulin. Adrenomedulin is a 52 amino acid peptide with immune modulating metabolic and vasodilator activator. Adrenomedulin has a bactericidal activity and could be helpful in the evaluation of sepsis diagnosis and as a prognosis and in monitoring such conditions. Though less studied and used, adrenomedulin can be considered as one of the biomarkers of sepsis. Let us have again a quick review of this biomarker of sepsis. If we see procalcitonin, STREM1, and perception, they have there's a procalcitonin step 1 and perception. They have the prognostic as well as diagnostic value. If you see CRP, it has only diagnostic value. If you see the pro-ADM and SUPAR, it has just prognostic value. So these are all the biomarkers of sepsis with the with the corresponding prognostic and diagnostic value. Now the issues. The biomarkers currently measured for the investigation of sepsis are generally measured in this central lab. It is usually performed at large chemistry analysis which employ LRODs and various immunoassay techniques. There's a delay in obtaining results because of the delay in the sample transportation to the central lab and the pre-analytic steps. So there has been more interest towards point of care testing that can be used to provide rapid results and reduce the time before appropriate treatment started. Sepsis should be diagnosed very early, and our delay can increase the sepsis mortality by about 3%. Hence, point of care testing is very necessary for the early diagnosis of sepsis, and point of care testing will help for the early diagnosis of sepsis and prevention of the control of the mortality. Like for example, lactate may be measured on portable POCT devices and on blood gas analyzers, which is equipped with a electrode measuring electrode. So that was about sepsis, the pathobiology of sepsis, and the markers of the sepsis and the blood culture that we have seen till now. Now the other most important thing, antimicrobial resistance, which is another cause for the increased morbidity and mortality in sepsis. If the data in the Indian healthcare settings says that has shown that the ESBL prevalence, that is extended spectrum beta lactamase, that is resistant to the cephalosporins, the prevalence is about, it's nearly crossed 50%, as approached 70 to 80%. If you see the prevalence of carbapenems, that is resistant to imipenem, it has crossed 30% and it has reached 50%. So these are the most commonly used antibiotics, that is cephalosporins and the carbapenems as an empirical therapy in healthcare setting, and the resistance is increasing, and which is a serious global patient issue. So it is very important for every healthcare setting to implement an antimicrobial stewardship program to prevent and control this growing issue of antimicrobial resistance. It has been seen that among the, if you see the antimicrobial resistance gene, it has been seen in our healthcare setting. OXA48 is seen in about nearly 1/3 of the cases, or an NDM is seen in nearly 1/3 of the cases, and about OXA48 and NDM is also growing proportionately. However, KPC, IMP, VM is less seen as compared to OXA and NDM. That was about need of antimicrobial stewardship to prevent and control antimicrobial resistance. Also, the most important, other important thing which I kept in the last, but most important, is the infection control. Infection control goes hand to hand, parallel to parallel, along with the control of antimicrobial resistance. With the 5 elements and infection control practices that needs to be that is important. One is the careful choice of prophylaxis and antimicrobials to avoid the selection of resistant strains. Second, shorter hospital stays before surgery will help to decrease the risk of nosocomial infections. Then early removal of the catheters can reduce the nosocomial sepsis. Then routine use of personal protective equipment and hand hygiene should be done for prevention of healthcare-associated infection. Then application of infectious disease control measures to prevent cross infections. So that was about the infection control practices to be followed in healthcare settings to prevent the issues of healthcare-associated infections and also thereby prevent sepsis.